Today, as Vipriya mentioned, our topic of discussion is delirium. And we have Dr. Neil Arun from UK with us. He is a trained consultant in palliative medicine at Burjil Medical City. After completing his medical school at King's College London, he pursued specialty training in palliative medicine in London, with rotations in acute general hospitals, domiciliary visits, community hospices, and tertiary oncology centers. And prior to this, he was working in New Cora Hospital. It was a palliative care unit, and he was the medical director there. And Neil worked as consultant in palliative medicine at Imperial College Healthcare NHS Trust in London. He was clinical lead for palliative medicine there, and we are so glad that Dr. Nijhawan was the first licensed palliative care physician in Abu Dhabi and is licensed to practice all aspects of palliative medicine. And he strongly believes that for all patients, if one of the symptoms, when a symptom is well managed, they will feel better, both patient and the family. And his interest is in education and palliative care advocacy. He is the UAE representative to the WHO Eastern Mediterranean region palliative care expert network. And welcome you, sir. And we are all here to hear from you. Okay.
Okay, so I should go ahead and share my screen, I think.
Yes, sure.
Okay, okay, let me just do that. And thank you very much for the introduction. I think I need to abbreviate my introduction. It's far too wordy. But thank you for the very kind words. If I missed anything,
actually, if I missed anything, you can add on to that.
No. I usually try to keep the introductions much shorter. Okie dokie. So let's make a start. Can everybody see my screen?
Yes.
Yes, sir. Perfect.
Perfect. Okay, good stuff. So, as your introducers have said, my name's Neil. I'm a palliative care consultant. I trained in the UK, but working now in Abu Dhabi. I should say thank you for the organizers for giving me the opportunity to talk. I like teaching, so this is enjoyable for me. So thank you very much for putting up with me for an hour and a half, however long we have. So we're going to take a little bit of a run through delirium. This is not going to be a masterclass in delirium. That would take many hours, and I can't say that I'm an expert. But what we will cover are the common things, the things that we hopefully people will recognize in day-to-day palliative care. So we'll talk a little bit about what delirium is, its mimics, talk a bit about the symptomatology, some of the risk factors and the pathophysiology underlying delirium, why recognizing it is important, and how we manage delirium. So I've got about 30 slides. I don't think you need to make notes necessarily because you will have access to all the slides, and all of this information is compiled from all of the resources that people have access to via the miracles of the web. So I'll make a start and we'll deal with any questions afterwards or any comments. So like every other medical talk, we tend to start with a definition. So we know what delirium is. Everybody has an idea in the mind as to what delirium looks like. It's really a sudden, transient, usually reversible decline in cognitive function. And typically what you tend to see when that happens, there'll be aberrance or changes in a patient's conscious level, their attention and their cognition. And the longer you've been looking after a patient or been involved in the care of the patient, the more obvious the onset of delirium is. Like many things in medicine, and particularly in palliative care, the etiology or the things that give rise to delirium are multifactorial. And we'll go into some detail about this. Delirium is common. I went through the literature last night, just looking and just to get an idea as to what the literature says. You know, the prevalence is anywhere between 13 and 93%. But effectively, you know, almost all our patients will have delirium in the hours or days prior to death. So delirium is a very common symptom. And in our setting, in palliative care, it is a sign of impending death. And this delirium, particularly agitated delirium as part of terminal agitation, terminal restlessness, is particularly distressing for families. One, because of the impaired communication and often the aggressive behavior in agitated delirium. And for many family members, this terminal restlessness can often be the defining moment of a family member's dying process. And if the delirium is not managed well, it can actually leave families with quite a bit of distress and puts them at increased risk of complicated grief. So this is a very busy slide. Basically, you should just focus on the top greeny blue box as to what delirium is. So we've talked about, the disturbance in attention. And again, if you're being very, very particular, this is a UK slide. So we talk about asking the patient to go through the months of the year backwards. Actually, don't worry about how you assess it. Just look at the components that make it up. And this is according to the DSM-5 classification. So your patients need to have, disturbance in attention.
Code white, dental clinic, first floor, zone B, Bravo. Code white, dental clinic, first floor, zone B, Bravo. Code white, dental clinic, first floor, zone B, Bravo. Thank you.
Sorry about that. So for delirium, you require a disturbance in attention, disturbance in awareness, and usually there'll be other disturbances, memory, visuospatial issues, language perception, and it develops, suddenly, but can vary over the course of a day. And going through all of these slides, actually, in my mind, it's actually quite simple. The longer you've been involved with the care of the patient, the more obvious it is whether you're dealing with delirium, which can be attributed to something which is potentially reversible, or is the delirium simply part and parcel of the dying process? And then going into delirium a little bit more, you start delineating and breaking things down into your hyperactive or agitated delirium versus hypoactive. And the names are quite obvious. You will recognize this, those of us who have been working in palliative care. Your patient with a hypoactive delirium tends to be very lethargic, a bit more sleepier than normal. They tend to have a sort of cognitive slowness. They respond very slowly to questions. They often don't initiate movements or conversation, and they seem to have a sort of reduced awareness of their environment. If this is the first time that you've seen a patient, it can be mistaken for fatigue, depression, or even dementia. But obviously, dementia is something which is more gradual onset. Delirium tends to be much more rapid onset. By comparison, hyperactive delirium is what most people tend to worry about. And that's characterized by restlessness, agitation, hypervigilance, hallucinations, delusions. And again, if you've seen a patient for the first time who has some hyperactive delirium, you've never met them before, it can easily be mistaken for anxiety or psychosis. So particularly in diagnosing delirium, the one thing that makes a huge difference in picking it up and recognizing it is your familiarity with the patient. In the absence of familiarity with the patient, your collateral history comes into play a lot. And most patients in palliative care tend to have a mixed picture. So there'll be elements of both hypoactive and hyperactive delirium. But the main thing is that the delirium, whatever is characterized by overactivity or underactivity, there is a fluctuating course. And often because there is a fluctuating course, if the doctor or the nurse or the palliative care health worker assesses or sees that patient during one of their lucid intervals, they may not pick up on any delirium at all, which is why it's very, very important to have a collateral history. So I like seeing patients as much as possible with the person who's caring for them. And again, I've put this slide here. This is quite busy, primarily because this tends to come up in exams. How do you differentiate between delirium and dementia? So the cardinal things that the table on the left is actually the one to go for. So delirium changes tend to happen very, very quickly. Whereas dementia, you start with a little bit of confusion, memory impairment, and it gradually gets worse over a period of months. In delirium, the inattention and inability is to maintain focus and attention, Whereas dementia, their ability to focus is fine and they are quite alert until the dementia gets very, very severe. And while delirium has this fluctuating course with periods of lucidity, with dementia, the symptoms are generally quite constant. So this is just an important distinction. And again, it only becomes really a problem if you're seeing the patient for the first time. So there will be a bit of jumping to and fro through the slides. That's intentional. I put up the sort of the usual suspects in terms of the causes of delirium. This is taken from this nice review, references down in the right-hand corner. So if you look at all of these different, different causes, it's like anything in medicine, you know, the causes for delirium are multifactorial, and you could write books on this. So, you know, if you just take your typical palliative care patient, I'm going to pick a patient with, you know, advanced malignancy, because those are the most common patients I tend to see. You know, starting from the top, metabolic abnormalities are common. Many of our patients have a low sodium, many of them have a high calcium. If there's a lot of GI fluid loss, your electrolytes would be deranged. Many of the patients may have had chemo or radiation that can affect them both cognitively and physically. Sepsis screws everything up, as we know. If you've been looking after a patient for a while, they're losing a lot of fluid, everything else is normal, but they become dehydrated and hypovolemic. That alone can precipitate delirium. And, you know, as you go around, you know, endocrine changes, paraneoplastic changes, these are very, very common things. So although we're talking about delirium in the context of palliative care, delirium as a problem in medicine, particularly elderly medicine, geriatrics, is a huge problem. So simply being aware of the risk of delirium means that you're more likely to pick it up. And again, I'm not going to go through all of these. These are things that everybody should be familiar with or will at least recognize. And again, most medical things, I tend to remember things by mnemonics or little things that we learn in medical school. And again, this is just a different representation of that previous slide. But particularly for palliative care, drugs are the most commonly at fault factor in causing delirium for our patients, particularly because we use a lot of opioids, we use a lot of anticholinergic medications, and steroids can often cause quite florid psychotic symptoms. So it's worth being aware of these. Everything else in that list you're familiar with. So we know generally what the symptoms are. It's useful trying to understand something about what predisposes to delirium. And again, this is a very busy slide, but actually the take-home message is, you know, the younger, more fit the patient, the more insulting the physiological precipitant needs to be. So for example, somebody who's young and fit and has deteriorated rapidly because of their advanced, I don't know, metastatic gastric cancer, but is otherwise young and robust, it will take probably cumulative insults like hypercalcemia, sepsis, hypovolemia to tip them into delirium. By comparison, somebody who's much more frail, who has the cumulative burden of the insults that come along with, say, dementia in an elderly patient, all you need is a UTI or very, very slight hypercalcemia, and they tip into delirium very, very quickly. So as in medicine, as in much of medicine, if things happen very gradually, the body will cope and tolerate and compensate. But when things happen very quickly, that delta V is very steep, the body doesn't compensate as easily, and you tip into the delirium much quicker. And again, why do we spend a huge amount of time talking about delirium? Because it's a huge symptom, it's very, very distressing, and the outcomes for the patients are usually pretty poor. So we know that when patients become delirious, particularly in the context of ICU, they end up with a prolonged hospital admission, which means increased risk of institutionalization, potentially more disability, and delirium increases the mortality risk for all causes of death. So delirium is a huge problem. And again, this is a very, very busy slide. I tend to put these slides up, not that I want you to memorize it, I certainly haven't, but whenever you see slides like this, what I take away from it is the complexity. So given that there is so much complexity there in the pathophysiological mechanisms, The more complexity, the less clear the causative factors. So the more potentially that can go wrong, the more likely you are to have delirium. Yeah, don't take away much more than that. It's just a nice, pretty picture, quite frankly. So how do you actually assess for delirium? Now, this is one of many delirium screening tools. This is the, which one is this? No, this is an article which came out a number of years ago looking at the number of delirium screening tools that are currently in use. And none of them are palliative care specific. A lot of them do include inpatient palliative care services, but there are no palliative care specific delirium screening tools that I'm aware of or that I've come across in either my training or in a literature review. This is perhaps one of the better known ones, the MDAS, the Memorial Delirium Assessment Score. This is often used quite a lot in a research setting. It's a 10-point questionnaire, but it's very, very involved. It's easy once you start using it, but actually it's quite involved. RAS score is something that people may be familiar in the HDU, ICU setting. And the 4AT is something which has come out in the last, I would say, the last 10 years. And increasingly, this is used in palliative care research settings. And it's a nice, simple 4-step questionnaire for initial assessment of delirium and cognitive impairment. It doesn't matter which assessment tool you use. What is much more important is that you're consistent in your assessment. And again, I don't specifically use a particular delirium scoring or assessment tool. We tend to base it on clinical judgment. And because in my setting here in Abu Dhabi, I tend to do inpatient hospital palliative care. Generally, we've been looking after our patients for at least a couple of days, a week or two before delirium sets in. So it's easy to pick up. And again, I've rushed through that a little bit because the bulk of what I want to talk about is delirium management. And again, if all you take away from this talk is this slide, that's a good starting point. So the main thing with delirium, the main principle is you need to identify and treat the underlying cause. Is it reversible? Yes or no? If it's reversible, treat it. If you've treated it and the delirium episode continues and there's no other obvious cause for it, then you are likely looking at delirium, which is part and parcel of the dying process. We do spend a lot of time talking about the non-pharmacological interventions, optimizing patient environment, behavioral strategies, etc. These are certainly part and parcel of delirium management, but I would say more than 50% of the time, particularly when patients have an agitated delirium, so hyperactive delirium state, medications are required. So this, I apologize, this is another very busy slide, which is just a slightly fancier algorithmic way of saying what I've just said. You do have to aim to both reverse the delirium as much as possible, treat the underlying causes, while at the same time treat the symptoms to improve how the patient is feeling. If it's not possible to reverse anything pathophysiological, then the shift is towards controlling symptoms. And 9 times out of 10, you will end up needing to use a combination of medicines. So we're going to go into a little bit more detail now about delirium management. And before I even start talking about management, prevention is really the key. The best way to treat delirium is to avoid it happening in the first place. That is easier said than done, but it is worth considering. So in a palliative care setting, if a patient has delirium, invariably, patient is not comfortable. Ideally, we would like the patient to be up and about and awake and alert, not in pain, able to communicate. That's not always possible, but you can always do something to improve their level of comfort while you're trying to treat the underlying or the potentially underlying causes. And managing delirium, you do have to consider quite a lot of stuff, and you do this automatically, I suspect. It's only when you have a teaching session and you start listing things out like this, you realize how much it is you're actually doing. So you do have to be aware or have some consideration of safety considerations for both the patients and the family. Where's the best place to care for this patient? So if a patient is extremely agitated, requiring injectable medicines, home may not always be the best environment. for a multitude of factors. One of the things which is often not considered is actually when families don't understand why delirium happens, this is one of the things that tends to propagate and make the agitation much worse. Obviously, you have to treat and correct reversible causes and opioids and a number of other things just listed in red. Those are the main things. So in the palliative care setting, opioid dose reductions or opioid rotations are often done. I cannot tell you how often constipation and urinary retention precipitate delirium. It's treated very, very quickly and the patient settles without the need for more medicines. Hypercalcemia is often worth considering and treating because it does make a difference in treating it. It may not make a difference in terms of prognosis and time to death, but it certainly improves quality of life and improves their ability to communicate. And likewise, treating infection is always worthwhile if it's not overly onerous to the patient. But one of the real big things to keep in mind is that because delirium is such a distressing symptom, once delirium sets in, particularly agitated delirium, families will often say things like, look, the way they're behaving, this is not my mother. This is not the grandmother that I know. They would never behave like this. And so they're already starting to grieve and they lose even more because the patient now acts like somebody completely different. If the family is not aware that the risk of delirium is there, it can be part of the dying process, then everybody's level of agitation and distress is worse. And those of us who work in palliative care, you can tell one of the most difficult things to manage is you walk onto the ward and you've got a patient with very severe terminal agitation or restlessness, and you can tell because everybody on the ward is unsettled. If you have one patient with poorly controlled restlessness symptoms, that restlessness is very contagious, it spreads. And we often, I don't know whether people talk about this destructive triangle in delirium, but if patients, families, and loved ones and carers are not aware or haven't recognized or accepted that agitation is a symptom of the delirium, then you get this vicious cycle. But it's not so much a vicious cycle, more of a sort of destructive triangle, as it's phrased. So patient becomes delirious, agitation kicks in, the relatives and caregivers and family members, they then become more distressed by seeing that loved one and becoming agitated. The relatives then pressure the nurses on the ward, particularly to increase the levels of sedation or analgesia to alleviate the suffering, because they're convinced that they're behaving this way because they're suffering, maybe because of pain. And then often what ends up happening is there's an inappropriate escalation of opioids and or sedatives, leading to more sedation and increased risk of opioid toxicity and potentially more agitation. So if this is not dealt with properly, the level of agitation immediately around and surrounding the patient escalates exponentially. And if you don't manage it well and don't manage it quickly, families are often left with very, very bad memories of a loved one dying in agony. And I've had many patients who have wanted end-of-life care at home for different reasons, and things have been very, very well controlled until the delirium sets in. They've done everything that they can to treat reversible causes, but they've not been able to have, say, injectable medicines, and the delirium has been allowed to continue, and it's very, very distressing for them. So while the medications and interventions are useful, what is equally important is actually explaining to the family that maybe in 10% of patients who are dying, terminal restlessness, terminal agitation is a risk. And you do have to explain what happens. I mean, particularly, I haven't put this on a slide, but I think many people who have experience of looking after patients who are dying recognize that sort of low-level terminal agitation that can often start a couple of weeks before death. Typically, the patient doesn't know what to do with themselves. They want to sit up, then they want to change position, lie to the left, lie to the right. I want to sit down. I want to lie down. I want to get up. I want to walk. Almost this akaphysia, not knowing what to do with themselves.
First floor, zone B, dental clinic, all clear. Code white, first floor, zone B, dental clinic, all clear. Code white, first floor, zone B, dental clinic, all clear. Thank you.
Apologies for that again. And so non-pharmacological management or sort of behavioral modifications, these are often given sort of short shrift, and people tend to treat them with disdain almost, that they're less important than the use of medications. And actually, these are things that can be done very, very quickly. So I will actually go through this in a little bit more detail. So we know that if somebody is agitated and patients are coming to the end of life, patients will often have this plucking behavior, sort of grasping, hands are reaching out. The more lines, the more tubes attached to them, the more danger to themselves. So actually, really, we should be minimizing the use of these lines where possible. Same applies to physical restraint. I've been doing palliative care for about 12 years, so not that long. And in all cases where patients are physically restrained, we have managed without them. You do have to be inventive in how you deal with it, but there's usually a way around physically restraining patients. Early mobilization and prolonging patients' ability and need to want to walk and move around, even if it's limited, is worth doing. Because for many patients, there's a huge amount of frustration in not being able to do things. Sometimes patients have this mind-body disconnect. In their mind, they know what's going on, and they feel as if they can do everything, but their body has different issues, or the body disagrees with them. So when you get this mind-body disconnect, our patients really, really, really struggle. If you can allow them to mobilize even a short little bit, it can actually delay the onset of use of medications. Allowing patients to continue oral intake where appropriate for as long as possible is very recommended. This is assuming that you've had many conversations and discussions about the shifting from nutrition being only for nutrition's sake and calories to eating and drinking for enjoyment, for well-being. I don't know what it is. Maybe it's a cultural thing. Many patients that I look after, they don't want anything to eat at all. But if you offer them dessert, if you offer them ice cream, 90% of the time they will have something. And they do feel better for that. Visual and hearing aids, again, this is very important. If a patient is consistently, and has been for many, many years, utilizing hearing or visual aids for their day-to-day activity, if it's still appropriate, it's worth continuing use of these aids. Again, we've talked about dehydration. If pain is not well controlled, this will make any precipitation into delirium worse. We've talked about fluids and electrolyte balance. Bowel and bladder cannot be understated. And again, reviewing medications and minimizing polypharmacy as much as possible is really, really paramount. Reorientating communications with the patients. So familiar surroundings, familiar faces, familiar behaviors, which is why we try as much as possible. If patients want to be at home, we'll try and facilitate that. But if it's not possible, then we try to bring home to the hospital environment. Again, everything else there is quite commonsensical. We do tend to try to improve and have a regular sleep routine, so good sleep hygiene. That is not always easy, but trying to keep patients engaged as much as possible during the day tends to allow a more natural day-night cycle. Doesn't always work. And keeping a cool, quiet, calm environment at bedtime is always worth doing, whether you're talking about delirium or not. So these are the sort of non-pharmacological interventions, call them behavioral environmental factors, which are listed in every textbook, in all the literature about management of delirium. But the question is, how effective are these things? So if you look at some specific guidelines, so I've picked two at random. So the ESMO Clinical Practice Guidelines for Delirium Management in Adult Cancer Patients from 2018, and the most recent Cochrane Review on Non-Pharmacological Interventions for Preventing Delirium in Hospitalized but not ICU patients. Actually, the evidence base for these non-pharmacological interventions is not particularly good. It is not that they don't work. I think it's more that there is a lack of evidence because there aren't RCTs looking at this. A multifactorial approach certainly does reduce the chances of delirium. It can reduce the length of time delirium requires hospitalization. and it may reduce the frequency, but it has no impact on where the patient dies or prognosis. Now, this is not to say that these things aren't important, particularly in patients who are not cared for in a clinical environment like the hospital or inpatient hospice. These pharmacological interventions are really, really important. And this is where you draw the family members, you draw the carers in so they understand the changes that are likely to happen. They understand the need for peace and calm and quiet at the end of life. Jumping again to hyperactive delirium, just because this tends to monopolize a lot of the teaching in delirium. Essentially, if patients are a danger to themselves, despite non-pharmacological intervention, you've done all the behavioral environmental modifications, and they're really needing to be sedated, you really should be using medications at this point. There is no evidence for this. This is very much a clinical, pragmatic approach, but it's a common sense approach. You know, if there's a particularly neuropsychiatric predominance of symptoms, so the patient has a lot of hallucinations or delusions, you're likely to need to use antipsychotics. If the patient is very, very agitated and anxious, then you tend to need to use more sedative medications. And that's where benzodiazepines or Precedex tends to come in, particularly if the prognosis is felt to be very short. And again, in a case of terminal agitation, terminal restlessness, if it's the family's impression that actually this agitation is a source of suffering, you invariably need to use medications. And it may be that you use the medications in the short term, the immediate to short term, to improve their symptoms while you work in the background trying to reverse what is potentially reversible. There should not be this distinction between we cannot treat the symptoms because we're trying to reverse it. No, you can do both at the same time. So, talking a little bit more about the actual pharmacological management. So we've ascertained and got consensus that actually, yes, we do need to use medications to manage their symptoms. First thing to say is that actually whatever medications you're using, you need to regularly review these and stop them as and when the patient recovers. So this is often my approach. This is not the only approach. This is a commonly used approach in the UK, which is where I trained, and I apologize for the very, very UK focus here. First line haloperidol is still the most commonly used pharmacological agent for the management of agitation. We tend to use low doses, whether it's oral or subcutaneous or IV, on a PRN basis, and you may need to use a maintenance dose, especially if there's no reversibility. It is very rare that you tend to need an infusion dose of haloperidol of anything more than 5 to 10 milligrams in a 24-hour period. And it's important to say that actually there are newer generation antipsychotics, but all the evidence that I've reviewed shows that actually there's no evidence of greater benefit with the new antipsychotics. And these new antipsychotics may not be available in all jurisdictions. Haloperidol is cheap, generic, and effective. And again, I tend to use doses of 0.5 milligram, whether it's oral or injectable, and titrate up accordingly. If haloperidol is ineffective, second line can often be benzodiazepines, particularly if there is a strong anxiety component to the agitation. Let's be clear, benzodiazepines will sedate the patient and calm things down, but they don't improve cognition. If anything, will reduce the ability of that patient to communicate. Lorazepam is a good choice, again, 0.5 milligram, whether it's oral or sublingual. And I tend to use midazolam if I need something injectable. Again, 2.5 to 5 milligrams subcut Q1, or with a wider interval Q4 if they're particularly frail, or there's hepatic or renal impairment. Benzos are particularly useful if there's issues with alcohol withdrawal, sedative withdrawal, or even antidepressant withdrawal. Particularly in patients who've been on long-term antidepressants, they are actively dying, they're unable to take their antidepressants. Benzodiazepines can be extremely effective. And in patients with Parkinson's disease, again, this is a textbook thing. I very rarely come across this in clinical practice, but often the majority of antipsychotics have D2 antagonism. And the last thing you want to do with a Parkinson's patient is block whatever little dopamine they have. So you tend to use benzodiazepines a little bit more frequently in patients with Parkinsonism. So if haloperidol is your first line, benzodiazepines is the second line, isn't working, and you really, really do need to sedate the patient, we tend to use either bigger doses of midazolam, or if you need to and the situation requires it, you can give rectal diazepam. I often will switch the haloperidol to a more broad spectrum phenothiazine type antipsychotic like levomepromazine or nozinan. And again, I tend to use very low doses, starting with 6.25 milligrams as a PRN dose up to 12.5 Q2 to Q4. Generally, anything under 25 milligrams is less sedating, but actually even 12.5 milligram doses can be quite sedating in very frail patients. Once it is clear that you're dealing with terminal agitation and you do need to sedate the patient, I tend to give bigger doses of levomepromazine. And if we do need a continuous subcut infusion, the ranges of levomepromazine range anywhere from 25 to 200 milligrams over 24 hours. And again, there are alternatives if you're caring for patients in an environment where you don't have access to injectable medicines. So, oral or sublingual benzos, oral or sublingual medications like olanzapine can be quite effective. This is generally the first, second, and third line treatment, irregardless of whichever guideline you look at. My colleagues in America tend to be a little bit more hesitant to use haloperidol. They tend to worry a lot about QT prolongation. I think you need to be a bit pragmatic, particularly in patients who are dying. The priority is optimizing the symptom control very quickly. So on balance, I would say the priority is symptom control. I don't often see QT prolongation in patients at the end of life. I have seen it mainly in patients with methadone, and that's, again, very, very few, but the risk is there. So I've talked about sort of haloperidol, benzodiazepines, the phenothiazines. I haven't mentioned things like largactil, chlorpromazine, stemetil. Again, depending on where your practice is, your availability of phenothiazine antipsychotics varies. Generally, what you're limited by is the ability to give it in injection. Many of these phenothiazine drugs are quite irritant when you give them subcutaneously. You can give them IM, but IM injections can be quite painful. And in many of our patients at the end of life, they don't have significant muscle reserves. So you're often a little bit limited. When there's no choice and you do have to use it, these drugs can be very, very long lasting. Half-lives can be well in excess of 18 hours. So 1 to 2 doses a day are usually enough. This is the standard treatment. This is the mainstay of pharmacological management of delirium, particularly in the palliative care setting. Precedex, or dexmedetomidine, I can never pronounce it, Precedex, is something that is gaining favor. It has been around for a while now. It's a relatively new IV, typically alpha-2 agonist. It can be given subcutaneously. It's tend to find more use in the ICU setting. It's a very, very effective sedative, and ICU will often use it for analgesia as well. It is commonly used in ventilated patients, and it does improve their ability to communicate. And the big thing is that it doesn't affect respiration. So it doesn't affect respiration the way high doses of opioids or benzodiazepines do. The main issue with Precedex is the bradycardia. On the few occasions that I have used it, I've tended to, it's a fourth line when nothing else is working, or the level of sedation that the medications are producing is not acceptable either to the patient or the family. This is particularly in the setting here in the Middle East, where patients and families really struggle with the loss of communication. Again, these are the typical doses. There are many protocols for Precedex use online, so I don't want to labor the point, but it is an option. My suggestion is that you start this in ICU, get the dose stable before you shift the patient to the ward. And again, there have been publications specifically palliative care related, looking at the use of infusions of Precedex. This was a nice patient. There were only about 21, 30 patients. And they used standard treatment versus Precedex. What they found was actually half of the patients needed to return to typical antipsychotic and benzodiazepine use because Precedex simply didn't produce a deep enough sedation, and the family members in particularly struggled, and they felt that a higher level of sedation was required. So palliative care is nothing if pragmatic. During the stage of the illness where it's important to maintain communication as much as possible, Precedex may be an option, but you more than 50% likely need to shift to either antipsychotics or benzodiazepine as the need for sedation increases. And again, there are case reports. In the hospice, we have used this. In the UK, we've used it rarely. It depends on the practitioner's comfort with using medications like Precedex. I think I'm very, very lucky working in a hospital setting. We have been able to shift patients to the ICU, get them set up, stabilized on a dose of Precedex before returning them to the ward. It is an option, something to be aware of. So again, it's taken about just under 45 minutes. I've sort of run through Delirium very, very, very quickly. I've put up a few more references. The references that I have used have been stated on the slides, and I've also used quite a few references from Scottish Palliative Care Guidelines, Palliative Care Fast Facts, and the Palliative Care Adult Network Guidelines. All of these are freely available online, and those are my contact details. So that was a fairly rapid run through Delirium in the palliative care setting. And yeah, last slide. Thank you.
Thank you, Doctor. It was a wonderful session. I hope all of you got some idea about Delirium. And now we have a case presentation as well, Doctor. And before that, we will go with some discussion. I think all of you can ask any doubts you have to Doctor directly. As Doctor has mentioned, delirium is one of the most common symptoms as pain. Why? Because we see old age patients and we use opioids, and one of the toxicity signs of opioids is delirium itself. So we should watch for delirium, and we should know whether it is due to opioid toxicity or is there any other correctable cause like that way. So I'm definitely sure you might have come across many cases of delirium, and definitely there should be some questions in your mind. So you can open up and ask to doctor directly. We have an eminent faculty with us, and so we can come up with questions.
Good evening, everyone.
Yes.
I'm Dr. Priyanka. So I would like to ask, if we get a patient in terminal delirium, and does the patient has any conscious awareness? Like many times it might happen that the patient is probably having hyperactive delirium, mostly calm and silent throughout the day, but in between he or she might have like some episodes when he's shouting, having some hallucinations or delusions, and the attendant or the family might come up to us and ask does he know that we are here? Does he know what's going on? If we talk to him, will he be able to hear us and probably process it like that? So what is the scenario? Does that patient in terminal delirium actually has any conscious awareness?
Yeah, that's a very good question. So we know that delirium is a sort of transient, fluctuating phenomenon. There are periods when the patient is completely lucid, and you can have an absolutely 100% normal conversation. But there will be periods where they seem to have, if it's hypoactive, they have reduced awareness, reduced cognition. Eyes may be open, they may be looking around, but they're not interacting with their environment. And again, so I often have to, it's a very good question. You have to explain to the families that delirium can take that hypoactive, or it may take a hyperactive form. When there is that reduced awareness or the reduced cognition of surroundings, it is not always clear what the patient is aware of. And again, I tend to be very pragmatic. So if the family find, just from trial and error, that reassuring that patient reassuring the family members, explaining that you should be there, keep everything calm, don't argue with them, just validate what they're saying. Patients will usually settle down. If they don't, and you're in the process of trying to reverse things, then you may often have to use medications. But again, for me, the trigger for using medications is the patient a danger to themselves? Is it actually making the family very, very worried? Are they themselves getting agitated? Or do they feel that the patient is suffering? Then it is often quite reasonable to give the patient something just to calm them down. Because the other thing to bear in mind is if a patient is allowed to be very, very delirious with very agitated state and lack of sleep, that will often prolong the delirium. So it is worth sometimes breaking that cycle. But to answer your question, is the patient always aware? No, they are not always aware. They may appear to be awake, but that level of awareness and consciousness is low. The eyes are open. It's kind of like, the lights are on, but no one's at home type phenomenon. They seem okay, but they're not responding normally. So you do have to say to the family members, actually, no, from time to time, they may not know what it is they're saying. They may not be aware of who is around. And again, you do have to stress continually that there is a risk that terminal agitation, terminal restlessness may happen. It is probably present in, I would say, 10% of patients who are dying, more common in patients who are younger, in patients who haven't come to term with the fact that they are dying. And I think as we see more cancer, more dying in younger patients, you will see more delirium. This is just a biological fact. I hope that answers the question.
Yes, sir. Thank you. So one more question, actually. You earlier mentioned in the session that we can use certain behavioral therapies for the management of delirium. Can you just explain a little bit about it? Which behavioral therapies can we actually employ?
Yeah. So again, I didn't want to just have a million slides copying things from the internet or books. Everybody has access to these things, but these are, when we talk about sort of non-pharmacological interventions, we're talking about very, very simple things that you can do. So for example, we're talking about a patient with dementia, for example. We know that once you take a patient with dementia out of their common, their familiar surroundings, they get agitated. My granddad had Alzheimer's for 15 years. Whenever he got admitted to hospital, he would become ragingly delirious. As soon as we took him back home, he would settle down. No antipsychotics required. So there is something about familiar surroundings, familiar people, a familiar blanket, a familiar pillow or cushion, a clock or a painting from the wall that they recognize as being normal for them. Simple things like keeping the curtains open, maintaining good day-night cycle, and therefore good sleep hygiene. These are really, really simple things. If you keep the curtains shut all the time, this affects your day-night cycle, affects your melatonin levels, and it affects your ability to sleep. Simple things like keeping the room at a good temperature. We know that if families, want to put lots of blankets on the patient, often when patients are coming to the end of life, and I've worked in many places around the world, it's a universal phenomenon. They rip things off. The blankets come off, the clothes come off, they want to be naked. So actually less is more. This is what we mean by sort of behavioral modifications.
Yeah, I'm sorry to interrupt, sir, but does familiar surroundings be accounted into the behavior? Like, it doesn't sound practically to be like behavioral, some acclimatization or something.
No. So that's, you're right. That's more environmental. I mean, behavioral things like especially when patients are agitated. So again, this is learning from dementia. If a patient is talking absolute nonsense, the last thing you want to do is argue with them, because it will make the symptoms worse. So it's like treating dementia patients. You, in the background, you see what is possible to reverse, but you simply validate the patient, just reassure them. Say, yes, mama, or whoever it is you're talking to, that's okay. Everything will be okay. You tend to reassure. That's an example of behavioral modification. What else? I mean, simple things like, dealing with anxiety, making sure that somebody's getting their regular medications. If somebody is very, very depressed or very, very anxious, and you've omitted their medications, simply making sure that their medications are continued as much as possible decreases the chance of delirium being precipitated because they're now going into withdrawal. So again, it depends on your definition, but this is what we mean by the sort of non-pharmacological behavioral things. A lot of the behavioral stuff is to do with educating the family and the carers of the patient. If they don't understand why delirium is happening or why somebody may be getting agitated, rather than simply trying to keep things calm, they will also express agitated delirium in their expressions may be very distressing. Patients can feed off that, and that may make the delirium worse. So I equally spend as much time with the patient as I do with the families, educating them, explaining these are the changes that tend to happen. This is what may happen. This is what we might do. This is what we might suggest. These are the medications. To me, all of that comes under that very broad category of behavioral modifications.
All right, so thank you so much.
No worries.
Thank you, doctor. And we have another question by Dr. Ravi Shankar. Do you practice physical restraint for hyperactive delirium?
Yeah, good question. So I did mention this. I have never restrained a patient. That is not to say we're oblivious to the requirements sometimes. So often, we get referred a patient, we meet the patient and the family for the first time. The patient will often have a restraint and be tied to the bed. And then we'll start asking, actually, what is the issue? What are they actually doing? Are they actually taking the tubes out? Are they trying to scratch and itch? Are they, is this new behavior, or has this been their behavior all the time? Often with demented patients, the hands, they need to hold on to things. They like texture and touch. So if the patient has a particular toy or something that they generally tend to hold, you can often reintroduce that and the agitation settles and they don't need to be restrained. Sometimes restraining the patient actually causes more agitation, and then you end up having to use medication. So sometimes we will wrap mittens around the hand so the patient is physically unable to withdraw tubes, but they're not physically restrained to the bed. So I have never, I've been in Abu Dhabi for 3 years now. I have never come across a situation where we have not managed to remove the restraints. There's always something you can do. And this is where it's really, really important to get the collateral. Has this patient always been agitated? And I know what agitation is. What do you mean by agitation? Get the family to explain what agitation for that patient looks like. So I generally have always managed to find a way around using a physical restraint.
Thank you, doctor. Hope it's clear for doctor. And any other question?
Can I ask a question if everybody's being shy?
Yes, doctor, yes.
I've tried to use very broad medications to make it more applicable. Do you guys have access to all the medicines that I talked about in India? So I know you have access to haloperidol. I know you have access to midazolam. What about levomepromazine?
Dr. Priyanka, you are trying to communicate something?
Yeah, ma'am, actually I was saying that we have access to most of them, but not to the phenothiazine that sir mentioned. Probably in at least my setup, but the rest of those are pretty available.
Mm-hmm. So what can I ask then? What is your third line if haloperidol and benzodiazepines are not effective? What do you tend to use?
So mostly we are using dexmedetomidine.
And what is your environment? Are you in hospital or are you in the community?
So in hospital.
Okay. And is that ICU setting or just regular ward?
Yeah, so palliative care ICU also we have, and regular ward also we have in just case we have just taken a consent from the patient for palliative sedation sort of thing. In that case, we can shift to the ward also.
And can I ask, because I don't do it very often, do you put them on a continuous heart rate monitor?
So actually, frankly, we do not get that many patients for this condition. It's just like maybe once in a month or once in 2 or 3 months. It's like that.
Okay. Yeah, makes sense. I mean, I think this is something that has been drummed into medical education over the past number of years. With a globally increasing elderly population, dementia is more common, frailty is more common, therefore delirium is more common. So if I look at what medical students are getting taught about delirium now, and I look at what I got taught when I was at medical school, it's much higher up in the curriculum. It's certainly covered in more detail. There's a much lower threshold for it to be considered. So to me, that can only be a good thing because the world is getting older, and the older we get, the older our patients get, the more cumulative morbidity they have, the more frailty, the easier they are likely to get agitated. And again, I'll just add one more thing, particularly for me. I only speak English and very, very rudimentary Arabic. I can't stress the importance of making sure you get collateral history or translations in the patient's language, because I've seen a number of patients get inappropriately sedated simply because medical staff didn't know what the patient was saying. And once we've had the translation done, patient was making complete and utter sense. They were not confused, and they had all the right in the world and reason to be agitated. So again, communication is key, as in everything else in medicine.
Yes, that is one of the most valid point, doctor. I also come across such case in our setting. We had one patient from America, and his slang was very different from us. So we could not identify what he was telling, but we know he was communicating normally only. We didn't start him on any antipsychotics or haloperidol. We didn't start. Why? Because we know he was communicating normally, but we could not understand everything. So we should differentiate that. And doctor, we have a case presentation, but the Dr. Soumya, who prepared the case presentation, is not available today. If it is to be done, I can read out the presentation. We will move according to your opinion, doctor.
It is up to the faculty and the participants. Like if you want to have any exposure to real-time patient stories, we do have a case ready with us, but unfortunately, the doctor who brought in the case could not join the session because of medical emergency. So
alternatively, sorry to interrupt, I can give you again, I didn't put it on the slides, but it's in my head because it's a recent patient. Okay. We can talk through a case if you like.
Yes, doctor. Yes.
We would be really happy about that.
Yes.
Okay, you'll be very excited with the doses. So we looked after a very, very young guy. He was 23. It's an English guy with metastatic gastroesophageal junction tumor. And he had, as is typical for this tumor, he had a lot of intra-abdominal disease, a lot of metastatic burden, extensive peritoneal mets, liver mets. It's really the peritoneal and omental metastases which were causing an issue. And he had TPN, he had a nasogastric tube for decompression. He also had a venting gastrostomy because things were so complicated. So he had nasogastric tube for decompression, venting gastrostomy for decompression, TPN, and a urinary catheter. This is a 23-year-old ex-rugby player. And we looked after him for maybe 4 months, 3.5, 4 months. And over time, you know, he just became more and more green in color. You know, that sort of very funny complexion. And it was very, very difficult for everybody to look after this young man because he simply did not accept the fact that he was going to die. Neither him or his family accepted that there was no more anti-cancer treatment possible. He had perforations, he had multiple perforations, his liver function was bad, he was obstructed, he was tipping into renal impairment. So we couldn't give him any more systemic anti-cancer therapy, which didn't even work in the first place. So we were stuck in this situation, in a young man who was many, many hours away from home. Because his care was so complicated, we simply couldn't provide that level of medical support at home. So he stayed on the palliative care inpatient unit. And the week that he died, he became extremely agitated. It was a bank holiday weekend, and I happened to be on call. I was still training at the time. And he was on huge doses. He was on 180 to 200 milligrams of oxycodone. He was having big doses of PRN medication. He was having PRN methadone by injection. He was having ketamine. He had a ketamine infusion, 500 milligrams of ketamine per 24 hours. Eventually, we stopped the ketamine infusion because it didn't seem to be helping, didn't seem to alter his agitation at all. And he had very accelerated, hyperactive agitation. And eventually we started working our way through the ladder. He had escalating doses of almost 20 milligrams of haloperidol a day. It did nothing. We then started giving him midazolam. He had 50 grams of midazolam. And again, it did nothing for his delirium. I then started to give him 25 milligram PRN doses of levomepromazine. And this was all in the hospital setting. So we were, and again, I hate that we did this, but this was the only way we could manage it. We did so many regular blood tests to make sure that we weren't missing something clearly reversible. And there was nothing reversible. Nothing could be reversed. His electrolytes were bad. His liver function was bad. But again, it had always been bad. There was nothing to change. And so increasing doses of haloperidol, 20 milligrams of haloperidol, then 50 milligrams of levo, of midaz, it did nothing. He was still up and about, walking around on the ward, and getting increasingly agitated. At that point, he hadn't slept for 2-3 days. So he was getting very, very irritable. His parents were now recognizing that he was dying and said, look, you need to give him something to sedate him. This is when we started using levomepromazine. And we started using 25 milligram doses. We didn't bother with smaller doses. He was on, after about 48 hours, he had 200 milligrams of levomepromazine. In addition to all of those other medicines, nothing worked. So he was still GCS 14 because he was very confused, up about walking up and down the corridor, agitated, swearing, shouting at people, shouting at his mom and dad. And in the end, despite all of these medicines, I had to give him phenobarbital. So we gave him a loading dose of IM phenobarbital, followed by an infusion of, I think, 400 or 600 milligrams of phenobarbital, which finally settled him. And it didn't sedate him. It just calmed him down enough that he was able to sit down in bed, and we were able to care for him, and he was much more settled. But this was a specialist palliative care inpatient unit. And every day that I came onto the ward, you could feel the agitation and the unhappiness on the ward, because everything the nurses were giving was not working. Nothing was working for this poor guy. And so you can always tell. And so we use it as a training case. And his doses were extremely high. We even opioid rotated him off the oxycodone, onto methadone, onto ketamine, onto diamorphine. Nothing worked. It made no difference at all. And so sometimes, even doing the right things and systematically working your way through the doses, unfortunately, sometimes the only thing that does work is bigger and bigger doses. So if the phenobarbital hadn't worked, then the next step would have been a discussion with ICU and propofol, because he was so agitated. That's probably the most extreme case that I've had. And it's interesting, moving from the UK to this part of the world, I very, very rarely need levomepromazine. Haloperidol and midazolam are usually enough. Now, I don't know what the reason for that is. I'm aware that our doses of opioids that we use here in the UAE are much lower than, say, what we use in the UK. So you're constantly asking yourself, why? Why is this? I don't have a good explanation, but whenever we see such severe terminal agitation, 9 times out of 10, it's in a young man who has simply not come to terms with the fact that they're dying. And you try and support the family and allow them to vent that frustration, but sometimes you can't. And it's very, very difficult working in palliative care, you know, where we try to do the absolute best for a patient. And we take it very personally, because palliative care, you know, good enough is often not good enough. We need excellence. Sometimes you cannot achieve that. And it's very, very frustrating. And if there's clearly nothing to reverse, or you're trying to reverse and nothing is working, you are left with a patient who is symptomatic and unsettled, and you do have to use the medicines. And sometimes in extreme cases, you need to use very, very big doses of medicines. And again, unfortunately, this is what palliative care is particularly skilled at. It's juggling those big doses of medicines and the complexity. So, you know, where you don't have access to palliative care, certainly your ICU colleagues are a good port of call, because they're used to managing a similar level of complexity. So, you know, I think back to 12 years of palliative care, and that was easily the most difficult agitation that I've had to deal with. And all the difficult cases have usually been very, very young patients. So the more accepting you are, the less likely you are to have terminal agitation. The more in denial about your condition, the more you're fighting it, the more likely you are to be agitated. At least that has been my experience.
Thank you, doctor. It is one of the rare case, I think. In your career as well, you have shared that. And for me also, we used to manage with haloperidol and midazolam, and we used to manage this delirium very well with these two medications. But I'm also surprised to hear this case. Why? Because you have used the extreme doses of all the medications, and even after giving all these medications also, he was agitated, and anyway, he settled with phenobarbital. And I hope all of you got some idea about delirium, not some idea, very good idea about delirium. And doctor has shared one of the most rare condition. Usually we can manage the delirium. First thing we should do is to identify any correctable causes, if any. And one thing we should keep in mind is we should treat the patient as well as the family. Why? Because the family may be surprised why this is happening. Is there any, whether it is due to any mental disorder, like that way, they may think like that. So we should clearly tell the family that it is not due to any mental illness. It is due, sometimes it may be due to the disease as well, or sometimes there may be some correctable reasons. Usually, when we are seeing these cancer patients and all, even simple reasons may cause delirium. For example, even UTI or constipation, dehydration itself can cause delirium. Each of these reasons is correctable, and when the correctable reasons are corrected, and the delirium is a reversible condition mostly. But in some cases, it is not reversible, and so we should identify what is the cause of delirium. If we cannot find any cause only, we should move on to the sedation and all. First thing we should do is to identify the cause, if any. And we used to see delirium in opioid toxicities and as well as electrolyte imbalance. As doctor has mentioned, hypercalcemia, hypernatremia, all these can present as delirium as well. And also in late stages of this organ impairment and all, also there is a chance for delirium. So we used to see this commonly in our day-to-day practice as well. And alcohol withdrawal also present as delirium. So sometimes we may have to give this alcohol or something to avoid. What is your opinion on that, doctor? When a patient presents with alcohol withdrawal or something, how we will manage that?
Yeah, that's again. So this is why I like palliative care, because it allows us to be very pragmatic without being judgmental. Yes. So this is how I've managed it. Trained in the UK, we have a significant proportion of the population that do have alcohol. And so again, you know, okay, you look like you're having sort of rum fits or DTs, and you know how much alcohol do you normally have? What's your usual intake? And so if all that is required is to give the patient a glass of wine or a couple cans of beer a day, and then they are settled. To me, that's a much better quality of life than giving them haloperidol or midazolam. There's no sedation required. The patient is happy because they're getting what they want. Their agitation settles, and for them, it's a good quality of life, because the patients will often say to you, "Doc, I know I've got lung cancer, but I really enjoy smoking. What's the point in telling them to stop now?" There's no point. So you do. This is why, for me, I'm very pragmatic by nature. So palliative care as a specialty suits me. You can help your patient a lot by being very, very pragmatic. I remember when I was training, a lot of my senior consultants at the time, they would say, no, patient's got lung cancer. He needs to stop smoking now. I said, why? He's got stage 4 lung cancer. He's bedbound. He's not going to be able to have any systemic anti-cancer treatment. For him, it's either stop smoking to allow him to have home oxygen, or forget the home oxygen. He's comfortable having the 20 cigarettes a day. So it's balance, right? It's subjective. Quality of life is what the patient says is acceptable to them, is what the patient says is good for them. So if, the choice is benzodiazepines and antipsychotic versus 1 or 2 cans of beer a day, let the patient have their can of beer. What is the harm? In the grand scheme, in the bigger picture. That's my approach anyway.
Thank you, doctor. Thank you. And also, we should find any other correctable reasons. And if there is dehydration, we should hydrate the patient. And sometimes the catheterization or rise tube itself can cause delirium. They may not like that. Or sometimes ICU admission can cause delirium. And post-COVID also, we see many patients with delirium. Post-COVID psychosis also we used to see nowadays. And there are many reasons which is correctable. So we should identify the correctable reasons first when a patient presents with delirium. And one thing should keep in mind is we should treat the patient as well as the family. First, we should tell the caregivers and the family that it is not because of this, why this is causing. We should stand with them as well. Why? Because it will be very new to them, along with the serious health-related diseases. They are facing this situation also. Sometimes their close relatives may not be identifying them, maybe shouting at them. So it may be very difficult for them to cope up with their situation. So we should tell them it is not due to that. Okay, like that way. And another thing is there are types of delirium, as doctor has mentioned, hypo, hyper, as well as mixed delirium is there. And hypoactive delirium is very difficult to identify. Sometimes we may miss the delirium. So we should see whether the patient has delirium. Sometimes when we are going for rounds, they may not be very receptive, they may not be attending. They may be just picking and then dresses or giving a staring look at some places. They may not be answering to our questions. And so we should not miss the hypoactive delirium. That should be kept in mind. It is very easy to identify the hyperactive delirium, but some patients will present as hypoactive delirium as well. So there is any change we are noticing, we should keep all these things in mind while we are going for rounds. And some patients will present as both hyper as well as hypoactive delirium. And another thing is, as Dr. Priyanka has asked and Dr. Neil has explained that very clearly, just to briefing up, I'm just telling, there will be changes in cognition as well as awareness. There may not be change in every aspect. Sometimes they may be aware about the surroundings, but there may be slight change in memory, recent memory or past memory, like that way. So everything we should assess the conscious level as well as mini mental state examination we can do easily if we are suspecting any delirium. In some cases, in terminal delirium, we may not be able to do all these tests and all. So we should correlate it with the history of the patient as well as the present condition. And one thing we should keep in mind is we should make the situation very calm, their environment very calm, as doctor has mentioned, and we should familiarize the environment. with a clock we can place as well as the calendar. Sometimes they may be disoriented on time, place, and also we can use that. And we can make them look at the clock, and we can tell them the date. We can make them remember the dates and all, this date, and like that way. Another thing we can do is we can show them the photos of their family and close relatives and all, so they will get familiarized. And sometimes because in this delirium, the psychosis situation, they may be very confused, they may not, it can be easily reversed. In even in CVA cases, we used to see delirium. In those cases, there may be some alteration in memory and all, but when we are making them familiarized to the situation day by day, they used to get back. And one thing is oral thrush. We used to see most immunocompromised patient, and that is one of the most reason. And these are all conditions that are reversible, and so you should keep all this in mind. And another thing is, I feel that the patient may not be able to sleep and all. So the beep sounds and also the main reasons. And some patients does not prefer the style tube and all in their end stages. So sometimes they may not be able to tell, I don't want this or like that way. Sometimes they may not be able to communicate it properly. So they may be pulling out the style tube and all. Yes, doctor, yes.
Yeah, so that's a very good point. You brought up two things. So one, we often see patients who are very end stage and they need a nasogastric or a Ryle's tube for decompression because of a bowel obstruction. But many of them will say, Doc, I know we put this in and I know it was helping, but it's intolerable. I can't keep it in anymore. And they get really agitated for it. And so for those patients, I tend to, again, very pragmatic. I say, well, okay, we have a couple of choices. We can leave it in and I can use medications to try and make it more bearable, but those medicines will make you more sleepy. Or two, we can take it out, but you need to accept that in taking it out, the likelihood is that you will have 1, 2, 3 vomits a day, maybe. That is the balance, but at least it'll be more comfortable. And again, you have to have these discussions with the patients and the family. And I always reiterate to the family, I said, as much as we involve the family in all of the decision making, because it's the right thing to do, you know, our duty of care, prime duty of care, is to the patient in the bed. So as much as you can, you know, involve the patient in the decision making, because it's affecting them directly. And the patients will often say, yeah, and the family will say, no, no, no. And the patient said, I'm the one with the bloody tube, I'm taking it out. So that's good. When patients say that, I'm so happy, because they say it in front of the family. And then that brings me a second point, and digress a little bit. You know, with the breakdown in the nuclear family and the breakdown of the extended family, everybody's being dispersed. So now that what is it, the daughter-in-law from Canada or the daughter from New York phenomenon, you get a lot of family members, extended family members, who will come at the very late stages of a loved one's life. And if these people haven't been briefed properly, when they turn up and they start acting inappropriately, that means, you know, they're asking questions which have already been addressed, that alone can make, you know, the hyperactive delirium much, much worse. So again, it's always about the communication. The family members need as much time as you're spending with the patients, if not more. So just very important to bear that in mind.
Yes, doctor, as you have clearly explained that we should communicate it with the family and we should discuss it, everything. I think we have discussed all these things in our previous sessions as well. In everything, every symptom management, we should discuss it with the family as well as the patient. We should go with the patient actually. But if the patient is not conscious and all, we should stand with the caregivers or the family members. Why? Because if we are not standing with them, they will take away the patient from us, and we may not be able to give even little comfort care for the patient. So if we cannot make them understand, so we cannot make the family understand that this is the situation, and when the patient is not even able to express themselves, sometimes we may need to go with the family, even if that is not what needed. And another thing I would like to mention is doctor has explained everything, the non-pharmacological as well as pharmacological management. Mostly when a patient presents with acute episode of delirium, we used to manage with haloperidol, and we can give it subcutaneously. IV dose also available, tablet dose also, orally also it is available. So you can refer the dose and all, dosages and all in textbooks as well as in the presentation. And another thing is when it is not acute and all, when there is no correctable causes as well, we may need to sedate the patient. So we use the benzodiazepines as doctor has mentioned. And doctor, I would like to hear from you about the use of antipsychotics in delirium management. And as well as one more thing I would like to hear from you is we used to see in terminal stages of patients, we used to see hallucination. In some cases, it's not always common, but in some cases, the patient may be lying down very calm and all, but sometimes they may present with hallucination. They may be smiling, they may be crying, like that way. So in that state, sometimes we may be confused whether to manage that. I used to hear that there is something like when they are going near to the death, and so
Traveling.
yes. So I would like to hear from you that, doctor.
Yeah, so that's a good point. I mean, this is that concept of traveling.
Yes.
Yeah, so I've been fortunate. I've worked here. I've worked a little bit in the US, Caribbean. I've been to a couple other places, and this concept of traveling is global. It is ubiquitous to human nature. All cultures report it. And the patients themselves know that there is always this talk about these hallucinations, as you mentioned. Maybe 99% of the times they're associated with travel somehow, getting ready for go on a journey, packing their suitcase to take a flight. I've packed my bag, or I'm seeing my mother, or seeing very, very close first-degree relatives who have died. To me, this is part and parcel of the dying process. I don't medicate these patients unless they are agitated, it's causing distress to them or the family. If it's not, then I tend to sort of reassure, pacify, but I don't, I try not to medicate. If you think about a bigger picture, when people are coming to the end of life and we explain to relatives the changes that happen biologically, one of the things that we talk about is, patients tend to spend more time in bed, they spend more time asleep in bed, there's a withdrawing from this physical world, they tend to become more introverted. Again, depending on what your philosophical beliefs are, it's kind of preparing to leave this physical world and make that journey to the next place, wherever it happens to be. Part of that concept, again, it's universal. All cultures talk about it. I cannot say that medicine can explain it biologically, but it is something that we recognize. And because it's a ubiquitous, clearly unique human experience, there's no reason to fear it necessarily. And if it's not causing problem, it's not making the patient distressed, or they're not a danger to themselves, then halas, let them be. Keep them peaceful and comfortable. The bigger issue is not the patient. The bigger issue is explaining to the family members who may not have grasped it.
And doctor, I have one more doubt. If they are smiling and all, it is okay, but sometimes the patient may be crying. Like that way they may present. So whether we should let them experience that hallucination, or if it is both in positive or negative way, or we should...
Again, if they're distressed, then I tend to say let them have something to calm them down.
Okay.
And I explain to the families, look, we can't seem to stop them crying. They seem very unhappy. We'll give a little dose of this just so it breaks the cycle, so that they can have some rest, and let us see how they are once the medication wears off. Just break the cycle. That's what the medicines are good for.
Okay, thank you, doctor. Thank you. Actually, we have one case recently. I have experienced that in front of my eyes. She was in hallucination, but we cannot communicate that to the caregiver. Daughter was not accepting that, and she want her mother to be in complete comfort zone. So we cannot communicate that to the we cannot make them understand what it is, and we have given midazolam, and she was settled that time. So that time itself, I had a doubt how to manage with these cases. Very rarely we come across this type of cases. And one more thing is the use of antipsychotics like quetiapine and all we used to give for delirium. So I would like to get an idea from you on the use of antipsychotics. It is actually controversial in some cases.
Again, my experience has, I mean, controversial in that some family members may take offense or they take issue with the fact that you're giving their family members an antipsychotic, the same way that they say, why are you giving him an antidepressant? He's not depressed, he's not mad. So if there is some pre-existing stigma in the discussions, it will usually come up and you have to explain why you want to use a particular medicine. Again, there will always be cases where your best practice just doesn't seem to get through to some people. In those cases, it's important to keep the lines of communication open. What you don't want is you don't want to be at loggerheads with the family. You can very cordially agree to disagree, but equally be very, very clear where the medical team, in order for this to work properly, the rules of engagement are, we will do what we feel is clinically appropriate. We will explain to you what is going on, but you have to let us do what we think is best for the patient. That is usually how I deal with it. 99.999% of the time that works. Occasionally you get people who they just cannot get it out of their head. Occasionally you have to get mediation involved, very rarely. I've never had to do that. I would usually try very, very hard to explain to family members. It's just the preconceived ideas. So some family members, for example, will take real issue with you giving an antipsychotic, but they don't realize that actually the haloperidol that their mom has been taking for 3 years to manage nausea from chemo is an antipsychotic.
Yes.
And so once you make it contextual, they understand the relevance, people calm down. So again, if you look at everything, it always comes down to communication.
Yes. And the time is up, and thank you, doctor. Thank you so much for explaining everything. And I also got some better idea on delirium. Even though I saw cases and managed the cases in our day-to-day practice, it was an experience for me as well. I could hear from you on that rare case as well, extreme. You have used the extreme doses, actually, I should mention that. So it is an experience for me as well. In our settings also, we had on case, we used to give, that time we have given haloperidol 20 milligram in a day, as well as then, but with continuous midazolam infusion, the patient was settled.
Okay.
5 milligrams per hour continuous infusion, the patient was settled. But this is one of the rare case. So
I mean, if you think about it, that sort of normal distribution curve, most people will be in the middle. Most people will respond. This is how medicines are designed. Occasionally, very rarely, you will have somebody at the very far end, an outlier. That is not common practice. Most people behave a generally well-recognized way, and most of the standard treatments will work. It's just occasionally, when those standard treatments don't work, that's when you need to be calling for help.
Yes. So definitely it is a wonderful session, and we all get very good idea about delirium. I hope you all enjoyed this session and got a very good idea on delirium. Hope to see you all in next session, and over to you, Sri Priya. And thank you so much, doctor. We are so happy to hear from you, and we are expecting you to be with us in our upcoming sessions as well.
Good very happy. And
sorry to interrupt. May I just have one? Actually, I have one more query that I wanted to be clarified, if it's possible.
Yes, doctor.
Actually, like whenever we are having a patient being undergoing for this palliative sedation, we take a prior consent explaining everything. So in the case, for example, which sir mentioned earlier, that a patient might need higher doses of maybe a benzodiazepine or something, in that case, there is of course associated risk. We don't really know that when the dose might actually hit the patient, how the patient might actually respond to the patient, and he might pass away in an overdose. Quite probable. There is a risk associated. So in that case also, should we get a prior consent, or is it just implied? For example, if you're trying to manage delirium, probably it's not for the purpose of palliative sedation, but just if you want to manage delirium, we have tried the other things, but we are escalating the doses. There's a probability that the patient might pass away with that. So do we need a prior consent for that?
Yeah, that's a very good question. So this is the doctrine of double effect. You're doing one thing with the intention of A, but actually B may happen. I have to say that I'm always very, very clear with patients and families, and I say, listen, you know, this is the situation. This is very, very severe delirium or agitation. This may well be just part of the dying process. We are trying to do different things to try and reverse what can be reversed, but if not, then we will need to use medications to manage it. It is very rare. I mean, I have never done it. I have never given such big doses that it stops breathing or it stops the heart, primarily because we're not going from 0 to big dose. These are graduated incremental responses. So, you know, if you give somebody who's opioid naive 50 milligrams of midazolam bolus, yes, you will stop them breathing. But if this is somebody whose doses are gradually ramping up, it doesn't hit them all of a sudden like that. Something acute happening is usually because something else acute in the body has happened. Usually the renal function has acutely deteriorated. So I usually explain to family members that this is part of dying, and in trying to optimize these symptoms, we have to use increasing doses, which are likely to sedate. But I'm also very clear that at any point, and this is the inherent uncertainty of life care, everything may be fine, and then all of a sudden the heart stops. You know, it may not be a nice gradual process. Everything could be fine, and all of a sudden the patient will die very, very suddenly. The heart will just stop. We have no control over when that final moment takes place. It's difficult to say that, yes, it was the medicines causing it. But equally, is it standard practice to gradually increase the doses and titrate it according to symptom control? Yes. Is that a reasonable practice? Yes. Would a group of your peers in palliative care say this is a reasonable practice? Yes. So that's generally my approach. Everybody worries that actually the bigger doses you give, the more likely you are to overdose. But this does not happen. I mean, this is not something I recognize as happening. It may happen in people who are not trained in palliative care, who are not used to using the medicines that we use at the doses we use. But again, it's like everything else in life and medicine. If you do things very, very gradually, the body tolerates. It's when you do things very acutely, that is when the compensatory mechanisms get overwhelmed. So in answering your question, yes, I always say to the families that actually at any point in what we're doing, the heart can stop. We may not get any warning. Everything could be completely fine. You go into the bathroom, come back out, and they'll have stopped breathing, whether you give a bigger dose or not. So the dying is happening irregardless of the medicines we use. So this is why the language we use is very, very precise, and it's important to be precise so that there's no ambiguity.
Okay, thank you, sir. And what about, sir, are you in your clinical practice actually taking informed consent for palliative sedation, or is it also just like on counseling basis?
Yeah, so actually I haven't done palliative sedation since I was a trainee. I haven't needed to. I don't know whether that is because societally people are more familiar. I don't think so, because the general man on the street still doesn't know that much about palliative care. But maybe I think you know, people are living with, for example, cancer much longer. So they're used to having treatment. They're used to hopefully interfacing with palliative care on an acute admission. And generally, I think more and more people are getting exposed to palliative care. So the approach is more commonly used. I don't know whether it's because we use lower doses. I really don't know the answer, but I have not had to palliatively sedate anybody since I've come here. and much lower doses of medications are utilized compared to in the UK. Now, I don't know whether that is an epigenetic difference, whether it's because we have a bigger proportion of the Caucasian population that drink more alcohol, therefore their liver enzymes are upregulated, for example. I don't know, but there are clearly differences, but I haven't had to do palliative sedation on anybody here. We just, I don't know why that is.
Okay, thank you so much.
That probably doesn't answer your question, sorry.
No, so it's all right. Actually, we have just done it once or twice only, palliative sedation, and we just tried to be on the safer side and took the entire informed consent with the relative sitting so that later on something might not turn up against us. So I just wanted to know like what you or the other practitioners are doing, practicing.
Yeah, I mean, the very rare situations where you have had to do palliative sedation, these patients generally need things like propofol. And ICU care. And, you know, depending where in the disease trajectory you are, you may have to give fluids, you may have to consider enteral nutrition or other artificial nutrition. Whereas in somebody who is imminently at the end stages, you know, they're hours to days away, but extremely agitated, the only way to manage their symptoms to reduce the suffering is to give increasing doses of sedating medicines. That is just part and parcel of the symptom control. Some people may call that palliative sedation. If that's their definition, then yes, we do use increasing doses as required, but the doses we use are a fraction of what I'm used to in the UK, if that makes sense.
Yeah, all right, so thank you. Thanks a lot.
Welcome.
Thank you, Dr. Priyanka, and thank you, Dr. Neil, for your time and patience, and you have explained everything in detail, and we got very good idea on delirium, and we will share the presentation and this PPT as well, so you will get an idea and you can get back to the textbook as well. So over to you, Sripriya.
Thank you, Dr. Neil. We do understand that in your place, it is just half day through and still you found a time for this cohort of us and shared your insights and thoughts. And thank you especially for sharing your case, the real-time experience of yours. Thank you so much. And we, as Dr. Grishma said, we do look forward for more sessions with you on different topics as well. So thank you once again for joining us. And with gently reminding that, of course, all our sessions are sessions of learning, unlearning, and relearning. This is Sripriya, along with Dr. Neil and Dr. Grishma, signing off from the TIPS Eco Hub. See you in the next session with another different topic and yet another eminent faculty. Till then, everyone, take care. Bye-bye.
Bye-bye. Thanks so much.
Thank you.